Well, hello everyone. This is Dr. Amigues, your friendly rheumatologist. It's such a pleasure to be here. If you are watching this on replay, put a hashtag replay. It gives a little bit of visibility for other people who might be interested in learning about rheumatologic disorders. And the truth is that there's not a lot of rheumatologists out there in the YouTube or Instagram social media. Truth is, I don't necessarily like social media myself, but I know how important it is. I also know that we learn, might as well put some things that we learn from on social media, right? Um, and yeah, so if you do not know me, I'm Dr. Isabelle Amigues. I'm a rheumatologist. I was trained both in France, in Paris, and then Lyon in rheumatology. And then when I moved to the US, I did my another residency and another fellowship at Columbia University before moving to Denver, Colorado, where I first worked at National Jewish, which is a lung institute where I did a lot of work in interstitial lung disease and rheumatologic disorder. And then I opened my own practice because I got really mad at the insurance system. I continue to be mad at the insurance system with a big smile. I just think that doctors owe their time to patients and not to insurances. Okay, and so this is very important and very dear to me. I believe that the way that the insurance system has changed medicine, patients are not being seen by doctors anymore because it costs less money to be seen by advanced practitioner, which are wonderful, but they don't have the same training than physicians. And so physicians are now burnout, and I think it's just decreasing the care that we are giving to our patients. And so I think it's time for physicians to allow their patients to have the proper care. Okay, with that being said, that's me and that's what I believe in. I also love educating, and I love educating patients. I love educating fellows, residents, medical students. This is something I've done since the beginning of my medical training. I used to teach medical students, then residents, then fellows, and now and always patients. And now I just absolutely adore doing those rheumatology 101. Okay, so last week we talked about what scleroderma is. This week we're going to go a little bit more into details on how we diagnose it and how we treat it. And the reason they're together is that the way you're going to treat scleroderma depends on the presentation of scleroderma. And so, if you have not watched the previous topic, go ahead and go and look at the previous uh, um, Rheumatology 101 because we go over what scleroderma is and what manifestation it can have, right? And then let's say you have, you're wondering about scleroderma. Uh, the number one reason you are going to wonder about scleroderma is if you have thickening of your skin. If suddenly your hands are getting thickened and you are losing the, I want to say, wrinkle on your fingers, right? So if you're losing the wrinkle on your fingers, if your hands are starting to become puffy, and you feel like it's really tight to close them, that is the first sign of scleroderma. Sometimes you can also be itchy and you have itchiness of the skin. I'm showing here, it can be the forearm, can be everywhere on your body. Sometimes you feel like it's almost as if you have had Botox, but you haven't had Botox, or it's more than your usual Botox, and you're feeling like your skin is very tight, that you cannot open your mouth as well as you used to be. This is the scleroderma part. It's the thickening of the skin. This is super important because that's usually how we make a diagnosis of scleroderma. Everything else is a complication of scleroderma. It's not as obvious to make a diagnosis of scleroderma than the skin. Okay? The truth is that we're in rheumatology, and at this point, you know that it's an art to make a diagnosis and it's an art to treat. This is why it's such an interesting, field. Is that AI cannot deal like AI cannot take over for rheumatologists just yet. Maybe they will help at one point, but for now, it's a real art. And so then you have to think, okay, well, so I have the skin manifestation, then I have scleroderma. Like, if there is skin manifestation, then there is scleroderma. Sometimes it's not that obvious. And sometimes you have to think, okay, what other manifestation, like are those other manifestations that my patient has that could potentially be due to scleroderma? What are those? So the number one, the one that is the most common in scleroderma is something called Raynaud's phenomenon. Raynaud's phenomenon is when your fingers, the tip of your fingers, are turning white. They're turning white with cold. And it's usually an abrupt change in temperature. So what I mean by that is that, for example, it's the summer right now. You go to buy food, and you go in the cold section. And because it was so hot outside and so cold inside, that is when you're going to develop Raynaud's, because it's just this abrupt change of temperature. So you'll get this change of color. And if you've never had this ever before, that is something that you want to be checked, right? Like we want to check and see. Raynaud's phenomenon can happen for no reason, or it can happen for many autoimmune reasons. But definitely one of them is scleroderma. Other symptoms are the GERD, so the reflux. That is definitely a possible, like something that's associated. So if you have Raynaud's and you have reflux, something to think about, right? If you have joint pain, and not just the joint, it's also the tendon. You may even feel a tendon rub. We talked about that last time, okay? Those are like almost like the most common manifestation of scleroderma. And then you have complications of scleroderma, which can be really problematic. So lung disease, it can cause interstitial lung disease. So the main thing, the main manifestation is actually like having shortness of breath when you're walking. So that is, walking or running or going up on stairs, and it's something that you didn't used to have. Suddenly you're like, not you, sorry. Remember when I say you, it's not you. You don't, you're fine. But someone that you know, or maybe someone that you don't know, like something that you have to think about. If you're starting to have shortness, like patients are starting to have shortness of breath when they're walking up, or if you have some cough and the cough just doesn't go away, and so that's one of the possibilities, shortness of breath. You may have also chest pain, shortness of breath due to the heart. Those are like can be manifestation of your heart. Another one that's a big one that can be dangerous, and we have to know about it, is the kidney function. So scleroderma can cause something called scleroderma renal crisis, SRC, scleroderma renal crisis. And the way, like the reason it happens is that it's the same thing that in Raynaud's phenomenon, but of your kidneys. And basically, there is the vessel that's constricted, and you don't get as much blood flow in the kidney. Okay. You can also have GI issues. You can have like diarrhea, abdominal pain, inability to digest the food, stomach pain. That can also happen. So we have many complications from scleroderma. And the reason, so the way you diagnose scleroderma is if you have any sort of thickening of your skin, pretty easy, scleroderma. If you don't have that, but you have scleroderma renal crisis, then you have scleroderma. Sometimes you have other symptoms such as GERD, itchiness of the skin, joint pain that's inflammatory. You may have like the GI issues. You may have lung disease or heart disease. And sometimes it's hard to make a diagnosis because you can have scleroderma sine, which means without scleroderma. So it's the scleroderma disease without the scleroderma manifestation of your skin. And this is really where the art of practicing rheumatology is, because if that is what it is, you still need to treat the other manifestation as if it's scleroderma. And how do you do that if you do not know that this is scleroderma? And that's really when you want to make sure that you're seen by a rheumatologist as soon as possible. Because if you have interstitial lung disease, for example, and a positive SCL antibody, which is an antibody we see in scleroderma, or a positive ANA in a centromere or nuclear lab pattern, and you have Raynaud's phenomenon, I would argue that you have scleroderma. I would argue that you have scleroderma sine scleroderma, and that we need to treat your lung disease as if you have severe scleroderma. And that is really like what you want to see. So do you have scleroderma? Not you. Does our patient has scleroderma, skin changes? If that's the case, easy diagnosis. If you don't have that, do you have other manifestation of scleroderma? And if you have other manifestation of scleroderma, do you have a positive ANA, a positive SCL70, a positive RNA polymerase free? Okay, that's important. The other possibility is having an overlap syndrome. So overlap is exactly what it means. It's an overlap between several rheumatologic disorders. So you may have rheumatoid arthritis and an overlap with scleroderma. You may have lupus and an overlap with scleroderma. You may have mixed connective tissue disorder and an overlap with scleroderma. And so that may be a little tricky to make that diagnosis. We have some antibodies that are telling us that you may have an overlap. So PMSCL is polymyositis, and SCL for scleroderma, PM polymyositis, SCL scleroderma. So that is an overlap between very often polymyositis and scleroderma. And that is something to know, to look for, because the treatment are going to vary a little bit, right? And so then we go into how do we treat scleroderma? In general, we aim for remission. Remember, we are in 2024. We're like well into 2024. Our treatments are amazing. Our treatments keep improving. And so while, as you know, I'm a big on Eastern medicine and holistic approach, and I will absolutely recommend to do all of the lifestyle changes, I've also seen the change in medicine in the last, it's more than 20 years now that I am in medicine, much more than 20 years at this point. I won't tell you when it's 30 years because I don't want to age myself. No, I'm just kidding. But yeah, really, like, I have seen the changes in medicine in the last 10, in the last 15, in the last 20, but it keeps exploding. It keeps getting better. And in the last 10 years, we have new treatments for the lung disease, for the heart disease, for the pulmonary vessel disease, as well as for the skin, as well as for the joints. And so the goal is full remission. We may not achieve it, but that is our goal. We always aim for it, okay? If you have had scleroderma and that you haven't been treated properly to begin with, meaning that the diagnosis has taken forever, or that you were scared of treating it, so maybe our patients didn't take the medication when they could have, then you may have what we call fibrosis or scarring, and that is harder to get into remission, because once you have scar, it is hard, if not almost impossible, but I would never say impossible in medicine because you never know. It is hard to get back. But if it's just inflammation, we can get you to no more inflammation, okay? That is really important. So how do we get there? Well, first, we assess what manifestation of scleroderma you have. If the only thing you have is joint involvement, we may be okay with just plaquenil, which is not even immunosuppressive. If, on the other hand, you have severe scleroderma with interstitial lung disease, for example, that's progressive and very rapidly progressive, we're not going to wait. We're going to get you as soon as possible an immunosuppressive agent. That doesn't mean you're going to be on it for the rest of your life. It just means we start, and for a big fire, you call the Canadair. You call, the how do you call that? You call the plane with a ton of water in it and the product that are going to put out the fire. If you have just a little bit of fire, you just put a little bit of plaquenil, a little bit of a pipette of water. That's enough, right? And so that's really what how we think is. Do you have, number one, what type of manifestation do you have in scleroderma? Do you have kidney involvement? If that's the case, if you have scleroderma renal crisis, there's actually ACE inhibitor that have changed the outcome of scleroderma renal crisis. If you have lung disease, we know that mycophenolate mofetil works really well for interstitial lung disease. We know that also Rituxan can work really well. If you have skin disease, we try first with MMF, myclophenolate mofetil, or methotrexate, and then we can try with IVIG. We also know that tocilizumab, which is a biologic, can really work. Rituximab can work on skin disease. Sometimes it's a combination of things. But we really try to find the exact amount of immunosuppression you need to go in full remission. Once we get you in full remission, we wait a little bit. Then, if you stay on remission, we start backing off, because the goal is to get you with the least, not you, patients, to get our patients with the least amount of immunosuppression in full remission. Okay? Then we have a couple of other things that you need to know. If you have GERD, and if you have GERD, so the reflux, we want you to not eat for 3 hours before you lie down, and we want you to lie down with the head elevated. It takes a little while to get used to it. I know that I'm a stomach sleeper, so it's a little bit hard. I don't like pillows, but the truth is that if I had GERD, I would absolutely do it, and I would get used to it. And maybe what you can do is take a wedge and increase the weight slowly until you're used to it. That will change things, because what happens is with the GERD, you have a reflux of the content, the gastric content. So the stomach, from your stomach, you have food and acid that come up and they go into your lungs. And we don't want that, because then it's not really due to, it is secondarily due to scleroderma, but it is not an inflammatory process. And we don't want that. We don't want to damage your lungs because of the gastric content that's inside your stomach, because there is acid. It's not just the food, there is acid, okay? So that's number one. You can also take calcium channel blocker, which are going to decrease, are going to help with your scleroderma related Raynaud's phenomenon. Because the problem with Raynaud's phenomenon is that you can have ulcers and ischemia. So, almost like a loss of the fingertips. Like, it can be as severe as loss of the fingertip if you have severe scleroderma. So that's important to do. We have also vasodilator that are, much more powerful if needed be. Same thing for pulmonary hypertension. We have now incredible treatments. And I would say that if you have scleroderma, I would highly recommend that you get seen by a team that has a multidisciplinary approach. I personally work very well with my colleagues at National Jewish. One of my hero, and I really say it, is Dr. Patricia George. She's come on the podcast on Abridge MD several times, because she is one of my hero. She is incredibly good in pulmonary hypertension, and I love the work that she does in pulmonary hypertension, both from a scientific perspective as well as mindset perspective for our patients. And if you don't know her, I would highly recommend you look at the Unabridged MD podcast that she's been on, because she's just a powerhouse. And then, we treat depending of, like, each of the manifestation can have a treatment that's not necessarily just immunosuppressive. So we do that, okay? In general, again, the most important thing that I want you to leave with is, one, scleroderma is very rare, very, very rare. Okay. But two, we have treatment, so it's hopeful. Three, the most important is to make a diagnosis as early as possible, because the earlier we treat, the less complication you get, and the faster we get you to remission. And that means living a fully complete normal life. Okay, so that's important. And get seen by someone that knows what scleroderma is, because it is rare. Not everyone has seen scleroderma. Not everyone can deal with that. Okay, that's important. And then the last thing is, make sure that you're part of a team. It's not just your rheumatologist. It's your rheumatologist, maybe your gastroenterologist, maybe your heart specialist, maybe a pulmonary specialist, maybe, all of the above. You may be sent to occupational therapy to do some exercise with your hands, and so on. So just remember, one, we need to make a diagnosis as early as possible, and two, we need to tailor treatment specifically for you. There's not one size fits all. It's literally tailored to you. Who are you? What do you need? And what I'm saying, the patients, what do they need? How do we treat them? Okay. So that was the gist of it. Hopefully this was helpful to you. This one's a little bit further done. It was 20 minutes more than I usually do. Hopefully it's all good. I hope you enjoyed it. I'm seeing Nicole. Hi, Nicole. Oksana B. Loska. put your name. If I'm not saying it properly, don't hesitate to let me know what it is. Dr. Tina Wheat, and then Heather. Such a pleasure to see you again. If you are you're listening to this not live, don't hesitate, and please put replay. And I hope to see you next week. If you enjoyed this podcast, if you know someone that will enjoy it, share it with them. Okay. Have a wonderful day, and I will see you next week. Bye bye.